Brilliant. Okay, right. This is room two of our research abstracts, and we're ready for our very first presentation of the afternoon. So, Palesa, thank you for joining us. Would you be able to put your camera on while you talk to us? If that's possible, that'd be great. And I'm going to give you,
Um, I'm sorry,
that's
my
awesome.
window's a bit open. Is that fine?
That looks great. Yeah.
Okay.
Great. Thanks, Palesa. Take it away. Tell us about your acute gastroenteritis study.
Okay. Hi, guys. My name is Palesa Makekeng, and I'm a clinical associate with the Vitsvita Research Unit at Chris Hani Baragwanath Academic Hospital. More specifically, I work under a study called CHAMPS, which stands for Child Health and Mortality Prevention Surveillance, which was covered by Prof. Ziyaad yesterday, because we work under him. Um, And in this abstract, we'll be looking at acute gastroenteritis mortality for children under the age of 5 in Soweto, looking at the findings from the minimally invasive tissue sampling from 2017 to 2025. So I'm here to voice out that we've seen quite a lot of babies who die from what has deemed to be a preventable condition. So that's what we'll be looking into today. Can my slides move? Oh, there we go. Great. So looking at the global burden, we see that 1.7 billion childhood diarrheal diseases are reported annually, with around 1,200 deaths recorded daily, although there's been a decline of 79% since the 1990s. So sub-Saharan Africa tends to take the hardest hits with around 150 deaths per 100,000, which is quite a high number. And in South Africa, we've seen that in 2022, 23% of vaccinated hospitalized children were shown to have rotavirus, which is quite a high number because we've had preventable interventions such as the rota vaccine and improved wash, and treatments such as ORS and zinc supplements. And this number is still quite relatively high. So let's look at the determination of cause of death methods. Overall, people tend to lean more towards clinical information or complete diagnostic autopsies or verbal autopsies, which are similar to family interviews. Although these are quite helpful, but when used in isolation, they tend to be less accurate. That's why we have CHAMPS. CHAMPS combines all of this information into one to try and yield the most accurate data for deaths under 5 and in stillborns in low to middle income countries. And how do we do that? Through what we call minimally invasive tissue sampling, which we'll get into now. So, what are our study objectives and aim? What we are looking to achieve is to look at the prevalence of acute gastroenteritis in children under the age of 5 in Soweto, and how we're planning on doing that through looking at this prevalence through age, gender, and HIV status, and also looking into the etiology behind these AGE deaths. Now, as some of us here know, Soweto is quite a large population. It's a lot of ground to cover. That's why we work hand in hand with the HDSS, the Health and Demographic Surveillance System. So these people are able to map out Soweto to try and see the areas with the higher child mortalities. From there, we were able to get 8 clusters in Soweto and 6 clusters in Thembelihle. Where do we get some of these notifications? From Soweto hospitals, forensic pathology, and community notifications. So these participants are enrolled prospectively and the clinical data is analyzed retrospectively. Who is eligible for the study? Well, children under the age of 5 and stillborns above 28 weeks gestation and or above 1,000 grams. The death has to be within 72 hours and the child has to reside within the catchment area. After the death notification, informed consent and verbal autopsies are obtained, followed by the MITS procedure. Then the decode panel, which is a determination of cause of death panel, is able to assign a cause of death to the baby. And 180 participants are enrolled per year. So what is the MITS procedure? Where do we take the samples and what tests are the samples run for? So firstly, we identify the baby, we prepare for the procedure, then we take measurements, pictures, cerebrospinal fluid, blood, and a nasal swab. Then biopsy samples from the liver, the lung, and the brain are collected, and finally a rectal swab. The tests that are run on these samples are microbiology. We also check HIV, TB, malaria, Tachman's-Ray, and we also check for histology. So after all of this information is gathered, from the clinical information to the post-mortem results, the VA, all of this information is combined and taken to what we had said is the decode panel. So who is part of this panel? We have pediatricians, neonatologists, obs and gynae, microbiology, histopathology. We also consult with forensics and genetics. These panelists are then able to assign a cause of death using the World Health Organization causal pathway. And then they are coded using the ICD-11 codes. After the cause of death is assigned, the family can receive the results and public health recommendations can be made. So looking more specifically into the rectal swab, what do we do with it? So the lab receives it dry, it's sterilized using the PBS, it's frozen, and total nucleic acid is extracted. Then the Tachman's-Ray can be performed, and the results are interpreted through what we call cycle threshold CT values to try and indicate the pathogen load. Around 45% of pathogens are assessed through this process, including rotavirus. Now, this is the total number of cases that we've seen across all age categories for children under the age of 5. But in our analysis, we looked more specifically into infants and children, which gave us a sample size of 455. Out of this, looking at gender, we see that 44 were male, with 56 being female. And out of this, we see that 6% were HIV positive. Now, boiling it down to just acute gastroenteritis cases, we see that they accounted for 13% of the total analyzed deaths, which is quite high if you look at 455 cases. And looking at breaking them down into age categories, 12% were infants, with 14% being peds. And now, if we just zoom in on these AGE deaths and breaking them down into the age categories, we see that majority were infants, which is worrisome also. Looking at age category, gender, we see that 50, I can't even see my slides from the side. We see that 50, majority of these were male. And out of these, we see that 7% were HIV positive. And of the total number that was analyzed, it was 1% lower. It's just something to look into also. Looking at rotavirus specific cases, although 55 out of the 59 samples we have results for, we were still able to see that out of those, 20% did show to have rotavirus present. And out of those, once again, majority were from infants, with 91% and 9% being peds. Now, we had said that the panel is able to check and analyze the cause of death. It's also able to see whether this death could have been prevented. And from this,
Palesa, sorry to rush you. Can you wrap up at this point?
Okay. No problem. I'll get to it. From this, we're able to see that 69% of these could have been prevented, close to 70%. And where rotavirus was present, 64% of these could have been prevented. In conclusion, we've seen that acute gastroenteritis accounted for 13% of the total deaths. And out of those, majority were from infants with 66%. 20% showed to have rotavirus, with once again, 91% being from infants. Although vaccine status for these children isn't really known, HIV vaccine coverage in Soweto is quite high with 91%. 69% of these deaths were shown to have been preventable, and analysis for the other pathogens is still being tested. And acknowledgements, we'd like to thank our funders, our clinical and lab support, our decode panelists, and the study participants and their parents for the bravery of participating in our study. For more information, you can look into the local, the local data from South Africa and the overall CHAMPS website.
I saw a QR code there. Is there a QR code in your last slide? There we go. That's it. Brilliant.
Thank you.
Wow, that's amazing. Palesa, thank you so much. That's really interesting. Gosh, amazing what you can do with that particular methodology. Absolutely brilliant. Cool. Thank you very much. Okay, I'm going to hand over to my co-host Nomlindo. Do you want to call our next speaker?
Thank you so much. Good afternoon, colleagues. I'm going to introduce our next speaker, which is Sheree. Sheree is from Vets Vida, will be talking to us about etiology of deaths attributed to meningitis in children under 5 in Soweto, South Africa. Looking forward to hear from you, Sheree. Thank you.
Thanks, everybody. Can you see my screen?
Yes, we can.
Okay, great. Sorry, I'm just starting the presentation. Okay. While we wait for it to load, my name is Sheree, and I'm a clinical associate within the CHAMS team at Vets Vida, and I'll be presenting on the etiology of deaths attributed to meningitis in children under the age of 5 in Soweto, South Africa, from 2016 to 2025, using post-mortem data provided by the Child Health and Mortality Prevention Surveillance, or the CHAMS network. So meningitis remains a major cause of mortality among children under 5 in sub-Saharan Africa, and the data describing the causes and comorbidities associated with meningitis-related deaths in South African children remain limited. So globally, I just want to go to the next slide. Why is it moving to the next slide? Oh, there we go. Globally, in 2019, we saw that children under the age of 5, there were approximately 1.28 million cases or incidence cases of meningitis. And from that, there were approximately 112,000 deaths. And then in 2021, globally, children under the age of 5, the incident cases decreased to 1.02 million cases, and the deaths also decreased to 91,000 deaths approximately. However, it still remains a burden of disease. And then in South Africa, in 2019, under the age of 5, the incidence cases were approximately 34,000 cases, and the deaths were 4,130 deaths. I'm just trying to get back to slideshow.
Oh, sorry again. It's not on slideshow, it's on presenter view. Can you please try again to put on slideshow? Thanks.
Yeah. Can you see it now?
It's not showing at all.
Can you see it now?
Yes, but put on slideshow.
Better. Okay. So you can see it, right? Okay. So the aim was to describe the mortality associated with meningitis in children under 5 in Soweto, South Africa. And our objectives were to use minimally invasive tissue sampling, or the MITS, to determine the proportion of deaths due to meningitis by age group, and then also identify pathogens responsible for meningitis-related deaths among children under 5. As mentioned in the previous abstract presented by my colleague, Palesa, we use the same methodologies. So CHAMS uses active mortality surveillance with hospital forensic and community recruitment. Our eligibility is children under 5 who died within 72 hours and are residing in the catchment area as established by the HDSS team. And the process includes consent, verbal autopsy, MITS sampling collection and decode panel review, integrating lab, clinical, and histological data. So that's the MITS procedure, and it allows minimally invasive collection of blood, CSF, and organ tissue. The samples undergo culture, TAC molecular testing, and histopathology, and that gives us a pathogen level certainty that routine surveillance cannot provide. Other methodologies, again, my colleague spoke about most of this, but essentially after sample collection and clinical data review, a multidisciplinary or decode panel assigns the causal chain of death using ICD-11 coding. And this includes identifying underlying, immediate, comorbid, and other significant conditions attributed to the death being analyzed. The panel also assesses preventability, which is critical for health system improvement. Then if we look at the meningitis case breakdown, among the 1,201 cases that we identified for under 5 deaths, 184 of those had meningitis in the causal pathway. Most of them were comorbid conditions, so 77.2%, showing that meningitis frequently occurs with other severe illnesses. And approximately 19.6% were immediate causes, and about 3.3% were underlying causes, or meningitis was in the underlying causes. But most importantly, 95.1% of these deaths occurred within healthcare facilities, emphasizing the importance of early detection. And if we look at it by age group distribution, we note that neonates had the highest proportion of meningitis-related deaths, at 16.2%, and then infants 15.2%, and children at 11%. Then our pathogens, from our cross-site summary, we can see that the pathogens vary strongly by age and whether acquired in the community or hospital. Neonates had high rates of gram-negative bacteria, especially in hospitals, and this visually shows a significant burden of healthcare-associated meningitis, aligning with the 95.1% facility-based deaths. And if we break it down into our top 5 pathogens that we've identified, it's A. baumannii, Klebsiella pneumonia, Streptococcus pneumoniae, which is an important community pathogen as it is vaccine preventable. Group B, Streptococcus, which is relevant for neonatal sepsis and meningitis cases, and E. coli. For our preventability of the 184 meningitis-related deaths, 126 of them were considered preventable by the DCODE panel, and this reflects opportunities to improve our prevention strategies. In conclusion, meningitis contributed to 15.3% of all under 5 deaths investigated between December 2016 and August 2025. And then majority of meningitis-related deaths occurred within the neonatal period. However, the proportion of deaths due to meningitis was similar across all the age groups. And then the top 3 causative organisms identified are A. baumannii, Klebsiella pneumoniae, and Streptococcus pneumoniae. And then the DCODE panel determined that over 2/3 of meningitis deaths were preventable. And it's important to note that further analysis for the final manuscript is still underway. And then just for our acknowledgements, our funding, the Gates Foundation, our clinical and laboratory teams, our DCODE panelists, and the families who consented to MITS. Thank you.
Wow, thank you, Sheree. Very valuable presentation. We do have 1 minute for any questions.
So our next speaker is from the Research Centre for Maternal Fetal Newborn Child Health Care Strategies in Pretoria. Martinel talking about the impact of antenatally detected placental function on early neurodevelopment. Thanks, Martinel. Look forward to what you have to share. I'm gonna restart the clock. Brilliant. Over to you. Thank you very much.
Thank you. Can everybody hear me?
Yeah.
Okay, good. Thanks, Dr. Roux, for the introduction. So my name is Marna. I'm a physiotherapist, and I am connected with the Research Centre for Maternal, Fetal, Newborn and Child Healthcare Strategies in Pretoria. My topic today is the impact of antenatally detected placental function on early neurodevelopment. Just my declaration and ethics statements. So the first 100 days are widely recognized as a crucial period for both fetal growth and brain development. But today, however, the focus shifts to the final plus minus 90 to 100 days before birth, a phase with on neurological outcome during the first 2 years of life. This period marks the beginning of the 3rd trimester, a critical window period for the continuation. These final days of in utero development lay the foundation for lifelong cognition, motor, and behavioral functioning. Growing evidence highlights the central role of the placenta within the mother placental fetal unit and its contribution to fetal development. Placental insufficiency, an incompletely understood pathological condition, is a major pathway not only to stillbirth, but also a key cause of fetal growth restriction among surviving infants. Late onset growth restriction, the most common and frequently missed form, typically emerges in the third trimester when uteroplacental perfusion is compromised during a critical period of rapid cortical and musculoskeletal maturation. It is detected through the umbilical artery resistance index, measured non-invasively using Doppler ultrasound. So here at home, placental insufficiency and the late onset fetal growth restriction are highly prevalent in low middle income countries. Ambiflow Doppler screening now identifies a previously undetected high-risk group of elevated umbilical artery resistance index. Early assessments like the general movement assessment, the Hammersmith infant neurological assessment, and like the Bailey, show consistent early motor neurological deviations in growth restricted infants. Typical developmental patterns include reduced fidgety movements at 3 months, subtle motor and cognitive differences at 6 months, and lower developmental scores among all domains at 2 years. It also impairs muscle growth, contributing to persistent muscle weakness. Early neurological and movement assessments are essential for timely identification of developmental delay, but unfortunately, neurodevelopmental data linked to antenatal Doppler indices remain scarcely globally, and especially in low middle income countries where the need is the greatest. The study therefore aimed to describe the neurodevelopmental trajectory of term infants aged 14 weeks to 18 months in the Tshwane District of South Africa, and to investigate its association with late onset placental insufficiency measured by the umbilical artery resistance index. So a prospective cohort study was undertaken. 74 term infants were eligible for the study. As part of routine antenatal evaluation, continuous wave Doppler screening of the umbilical artery was performed between 28 and 34 weeks gestation. Infants were divided into 2 groups according to the resistance index, of which the abnormal index is defined as values at or above the 75th centile for gestational age. That's according to Patterson et al. Abnormal, we had 21 babies with abnormal umbilical artery resistance index and 53 normal indexes. Hammersmith infant neurological examination were conducted to assess the neurological status of babies at 14 weeks, 6 months, 9 months, 12 months, and 18 months. Continuous variables were summarized as mean standard deviation or median IQR, and group comparisons were performed using t-test or Mann-Whitney test, depending on the distribution. So validated neurological assessment for infants aged 2 to 24 months, and that's the Hammersmith infant neurological examination. Cutoff scores for the predicting, it has cutoff scores for predicting movement disorders like cerebral palsy from 3 months in preterm and full-term infants that are published. It is also recommended in international clinic practice early diagnosis of CP guidelines, especially where general movements and the MRI are not readily available, like in low resource settings. So as you can see, that is the first section. It contains 26 neurological items divided into 5 sections: cranial nerve function, posture, movement, tone, reflexes, and reactions. Each item can score anything from 0 to 3, subscores per section. The total score is the sum of all 26 items with a minimum of 0 and a maximum of 78. High scores indicate better neurological function. The HIN also records age-appropriate motor milestones. as well as behavioral assessment of state of consciousness, emotional state, and social orientation. These sections provide only developmental context, but are not included in the global score. So birth findings of infants with abnormal resistance indices were consistent with impaired fetal growth, secondary to placental insufficiency, and they
Hi,
were
Nana.
born.
Can you
Hello?
please try and hurry up? You're almost on time.
Okay. Yes, okay, that was just consistent with placental insufficiency. Coming to the results, most hind total scores were similar across both groups at 14, 6, 12, and 18 months, but there were significant differences that was demonstrated at 9 months, where the hind scores were 72 in the abnormal group and 75 in the normal group. Apart from the lower total score, there were also significant differences in the subsection posture at 9 months in the abnormal group. The hind performer is clear in breaking down the risk of neurological abnormality, which increases in parallel to the increasing number of findings of scores of 1 and 0. So milestones largely comparable between groups. The exception for supported standing was significantly lower in the abnormal group at 14 weeks, but all infants achieved walking by 18 months. Behavioral scores were similar between the groups, consistent with previous findings that socio-emotional and cognitive deficits may emerge later in childhood. And then just my conclusion, abnormal antenatal umbilical artery resistance index reflecting placental insufficiency is linked to transient reduction in postural and total neurological scores in early infancy, indicating subtle motor delays and postural vulnerability, while most differences normalize by 12 to 18 months, but early screening at 14 weeks and 9 months may enable targeted and structured follow-up to support neuromotor and muscular development, and early identification to optimize outcomes for growth-restricted infants remain critical in resource-constrained settings. And there's just acknowledgement to the mothers and infants who took part in the study. I don't think they realize how valuable the contribution is for interpreting infant neurodevelopment in South Africa. Thank you very much.
Marna, that's amazing. I'm really interested. So if these assessments were being done by physios at these various time points, you would obviously then be giving feedback in real time and
Yes.
a little bit of therapy, and postural and some. And so, do you think the fact if these kids weren't having those regular assessments and those frequent contacts with the therapeutic team and assessments and interventions with the physio, do you think they wouldn't have caught up? I mean, is the reason that they caught up the fact that they were being screened? Or am I being too optimistic?
No, you're not optimistic at all. We are doing training in the Hammersmith infant neurological examination, and that is actually one of the things that we are teaching at the moment is that you can actually use through our clinical experience that we are teaching therapists to actually use the opportunity when doing the assessment to also kind of treat when you see some kind of a delay, because it's a repeatable assessment. So and the brain is so plastic so early on in life that even during one session where we now see that there's not such great a motor deficit, but that one intervention can shift the baby and just steer it in the right trajectory. So we've seen amazing things with baby shifting in one session. Yes, it would be the ultimate dream, of course, of mine to see that every baby receives a neurological examination. But
Absolutely.
yes,
No, I'm with you
that's a
there.
luxury,
I'm with
not
you.
only in private health, but
Yeah.
in definitely these days, by just listening to the last 2 days,
Yeah.
it feels like this is a luxury even in public
We're gonna,
health.
gonna,
But
have to hold you. Gonna have to hold you there. We're
yes,
gonna
okay.
invite Robin Smith to talk to us about some more developmental screening
Yes,
from
great
the Free
stuff.
State.
Looking forward.
Good afternoon to everybody, and thank you for this opportunity to share our work with you. So this one, slides on. This work was only possible through collaboration with colleagues, student field workers, interpreters, and our community partners, and we have no disclosures. Between the ages of 2 and 5, often referred to as the next 1,000 days, the brain is highly sensitive to stimulation and nurturing. During this time, children gain foundational cognitive, social, emotional, language, and motor skills. Yet in low and middle income countries, an estimated 250 million children are at risk of not reaching their developmental potential. Evidence shows that investing in early childhood yields some of the highest social and economic returns of any intervention. This is why both the SDGs and South African policy prioritizes access to quality early childhood care and education. Despite these strong policy commitments, several factors continue to undermine early childhood development. The National Thrive by 5 report card highlights poor dietary diversity, developmental delays, undetected sensory impairments, caregiver mental health burdens, and the uneven quality of early learning environments as major barriers. Alarmingly, up to 22% of 5-year-olds are already showing elevated blood pressure, signaling emerging health risks. Many children enter formal schooling already behind, and the gap continues to widen over time. ECD centres reach most preschool-age children in South Africa, yet remain an underutilised platform for delivering developmental and health screenings. Current efforts are fragmented, with limited coordination between the health and education sectors. As a result, delays, sensory impairments, and emerging health risks often go undetected. Too many children are missing the proverbial development and health train. Once that window closes, opportunities for early intervention diminish, and long-term outcomes become harder to shift. This presentation focuses on one component of our broader community-based study, the co-creation and refinement of a comprehensive screening model. Using the Polar framework, we developed the model through an iterative, structured, practice-based process that was shaped by continuous stakeholder input. Caregivers, ECD facilitators, interpreters, student field workers, and supervising health professionals contributed across 2 implementation cycles. Fieldwork took place across urban, peri-urban, and rural communities in the Free State, where screening access is limited. We recruited caregiver-child pairs, 3 to 5 years, who attended participating ECD centres, and we also engaged the ECD facilitators. Screening tools were selected for relevance and feasibility, and all data was captured on encrypted digital platforms. The initial multi-indicator screening protocol was developed by an interprofessional healthcare team and delivered on-site at ECD centres by trained healthcare student field workers under professional supervision, supported by student interpreters. The circuit-style setup enabled several assessments to run concurrently. Originally, caregiver and child visits occurred on separate days, with sessions lasting up to 2 hours. The slideshow shows the initial components of the screening protocol. The caregiver interview was very broad, covering caregiver well-being, the home environment, child health and development, plus caregiver anthropometry and blood pressure measurements. Children were screened for development, vision, hearing, and growth. ECD facilitator interviews provided contextual information on caregiving, infrastructure, the learning environment, and nutrition support offered at the ECD Centre. Between 2022 and 2024, feedback from structured workshops, debriefings, planning meetings, and on-site visits allowed us to continuously refine the model based on our real-world experiences. 5 key insights emerged. Operational challenges highlighted the need for same-day integrated caregiver-child appointments to minimize ECD disruptions and to improve caregiver-child participation. Session fatigue, especially for children, showed the importance of shorter, more focused sessions and streamlined workflows. Cultural and linguistic adaptations proved essential. Standardized tools were only available in English, and interpreter coverage was variable across languages. We translated instructions, and paired interpreters consistently with assessors, all participants, to build trust and enhance screen accuracy. Importantly, developmental readiness, rather than chronological age alone, should guide screening. This led to ability-based sequencing and adaptive screening pathways. Caregiver engagement is likely to improve when caregivers can accompany their children during screenings. And it leads to strengthening their understanding of their child's health and developmental status by receiving real-time feedback. Also, hopefully improving referral and intervention uptake. Together, these insights help ensure that our model was truly grounded in the lived realities of our families and the ECD centres. Age-based screening proved difficult for many of the children we screened, especially the sensory screening assessments, due to developmental delays and/or language barriers. This often resulted in test abandonment, incomplete screening data, or unnecessary specialist referrals. We shifted towards a tiered adaptive model guided by developmental readiness that allowed assessors to adjust screening tools based on each child's observed developmental readiness. The model also included clear referral pathways for either advanced testing and/or parent-led interventions. In our revised screening model, caregiver interviews were streamlined to focus primarily on children's psychosocial risk, development, and health. Vision screening was adapted to include only community feasible methods, and child blood pressure measurements were added. Here is a full visual overview of our final proposed screening model, which we use as a practical tool to facilitate implementation. This work shows that meaningful integrated screening is possible, even in resource-limited settings, when grounded in context and interprofessional collaboration. The refined model is flexible, culturally responsive, developmentally informed, and feasible for delivery by trained lay personnel, using portable screening tools. ECD centres can function as community screening hubs, generating actionable data for early identification and parent-directed support. If I can leave you with one message, every child deserves a fair start, and that begins with accessible developmentally informed screenings. I'm sure everybody's wondering what the financial investment for such a comprehensive screening kit would be. It is just over 350,000 rand, with other lower cost options available, as you can see on the screen. It is also important to factor in recurring costs associated with some digital tools, such as annual subscriptions, digital data management platforms, and screening tokens. Nearly done. So the next question that arises is, what would be the return on this financial investment? Heckman's curve comes from the economist Professor James Heckman, who spent decades studying the economics of early childhood development. His research has shown that the earlier we invest in children, the higher the return, especially before the age of 5 years. Investment produces an annualized return on investment of around 30%. So is the financial investment worthwhile in practical terms? From our project perspective, our data has shown that most 5-year-old screens were developmentally at risk or delayed, and several presented with sensory impairments, either impaired hearing or vision, reinforcing the need for early identification. Using Heckman's 7 to 13 times return on investment, you need to screen a relatively small number of children, approximately 100 to 600 children, to recover the full cost of one comprehensive screening kit. And we base that on about a 500 to 300 very modest saving on child future education and health services. But the real value is much greater over time. Applying Heckman's ROI multiplier, This initial investment translates into an estimated 2.5 million to 4.6 million in longer-term benefits through fewer developmental delays going unnoticed, fewer remedial education needs, earlier detection of health risks leading to cheaper health interventions, and improved long-term education and health outcomes. Investment in early screening proves both feasible and highly cost-effective. My last slide.
Okay, last slide.
Next steps. So next steps are to evaluate the model's feasibility, accuracy, and cost-effectiveness across diverse LMIC settings. The true impact of screening lies not in identifying the risk alone, but in how we translate these findings into meaningful support for parenting and early learning. To achieve this, we need a trained lay workforce to deliver these screenings at scale in ECD settings.
Brilliant.
Thank you for your attention, and my email address is on the screen if anybody would like to get in touch, and I'm happy to take any questions.
Brilliant. Robin, thank you so much. Sorry to rush you at the end there.
All good.
Definitely something that we need to consider. The return on investment is pretty compelling. Yeah, that's a very strong argument. Awesome.
And I think that is really the question. People often pose, somebody asks me, so what does it cost and is it worthwhile investing? And one doesn't, as a clinician, always, we also focus on the clinical impact, but we often forget to the powers that be sometimes, focusing on and being able to justify the financial investment and what the return is makes all the difference.
No, absolutely. Brilliant.
Thanks so much.
Cool. Thank you very much. Okay, so now we're moving from developmental assessments into pediatric rheumatology and a specific niche topic, which Wahima is going to unpack for us. So over to you. Thanks, Wahima.
So thank you, everyone, and good afternoon. Thanks, Dave, for actually putting me after Robin, because this presentation about musculoskeletal health screening actually follows on quite nicely. After developmental screening, we tend to do this kind of screening in the over 5-year-olds. So I'm really happy for the position in this list of talks. Okay, so Tin Soldiers, for those who are not aware, started out as a patient-finding organization, and they were looking quite specifically for the disease called fibrodysplasia ossificans progressiva. It's a really rare disease, which leads to bone formation in the muscles and in connective tissue, and ultimately leads to progressive immobility. But during the course of looking for these patients, Tin Soldier's team actually found so many other musculoskeletal conditions. And the two images that I have on the screen there are just of the documentary, the films that they've done about this journey. So the idea for this project was born there. As we know, even the Global Burden of Diseases study will agree that the number of years lived with disability for children with non-trauma related musculoskeletal conditions really has been increasing over the years, maybe because of increased reporting, but also because of increased awareness, I would think. So where did we start? We had a look at primary healthcare services in South Africa. This is where the majority of the public actually goes as first point of care. We know that primary healthcare services have so many roles that they need to play. We heard a little bit about the Ideal Clinic in talks yesterday. We know that these are nurse-led, but what we've also realized is that there are many nurses working at primary healthcare clinics that have in fact not had any or very minimal pediatric training, and therefore it came as no surprise that they also had no musculoskeletal education and no training in MSK skills. So Tin Soldiers had previously partnered with the Unjani Clinic Network for the FOP journey, and it seemed like a natural extension then to use this partnership to launch an MSK screening project. So the important part about this, I think, and we've also mentioned this in previous talks, is that these nurses actually live and work in the communities that they serve. And so they are invested in the health of the community. And that is so important, so that a project doesn't just become a project, it actually becomes a part of the healthcare system. It becomes integrated, and the health of the community improves as a result of that. So the actual aim of this project was to look, the part that I'm presenting to you today is to look at the needs assessment for what is actually required at a primary healthcare nursing level. How much do they know? We know what we would like to teach them, but that's not necessarily what they need to know. And it's important to have that kind of collaboration when you're designing any sort of training program. And then, of course, we would want to look at what the impact is of that targeted education program, not only on the knowledge that the nurses have gathered, but also how it's implemented into clinical care. So the needs assessment, this is just a summary of the methods. We looked, used an adapted version of the Hennessy-Hicks questionnaire. I'll talk a little bit more about that in a while. And based on the responses, we then designed a CPD accredited MSK program. And once we had a few nurses who had actually gone through the program, we got feedback from them and just to see whether we needed to adjust or change anything. So we had 93 respondents for the needs assessment, and the map really just indicates where in South Africa they are based. And we had a huge number of responses from the KwaZulu-Natal area. This is, of course, also where the majority of the Unjani nurse clinics are located, but also from Gauteng. And then there's a huge gap from the Northern Cape. I think this is probably because there's actually only one Unjani clinic in that area. So we just need to look into that a little bit more. Most of these nurses had been in practice for more than 5 years. And the feedback or the data we managed to collect from this assessment study really just reiterated what we already know, that the nurses have had no, majority of them have had no previous MSK training. And this pediatric gait, arms, legs, and spine screening examination has been around for over 20 years. I guess on the positive side, you could say that 52% were aware of this screening examination, but actually, less than half of them had never heard of this examination before. So we had our work cut out for us. And then in terms of barriers to training, I guess most of us can relate to time and staff shortages and lack of funding. But also we need to bear in mind that there are geographical barriers too. So if you're located in a rural area, it's quite difficult to leave your clinic. And I think this has also been mentioned before, to come out for training. So then we looked at what is exactly in terms of MSK education these nurses were requiring. And we structured additional parameters to the needs assessment questionnaire. So this is the first column on your left. And how this works is we ask the nurses to rate how important they feel these parameters to be in terms of their clinical practice. And then secondly, to rate again what their confidence is in their ability to deliver the service or to do what is required in these parameters. And then your training needs index is the difference between the two values. So in an ideal world, you'd want a difference of 0, meaning that they are doing well with the things that are important to their clinical practice. And as the numbers increase, that would then be an indicator of where additional training would be needed. So we can see here that the numbers for most of the MSK parameters were between 1.8 and 2.9 with the standard deviations there. And just to be sure that we weren't skewing the numbers in a way, we also looked at other parameters that was required in nursing practice at primary healthcare level, such as how well do you assess your patient's clinical needs and psychological health, and the others listed there. And for these, you can see that there is a mean difference of less than 1, and the numbers are closer to 0 than for all the MSK parameters. So these areas do not need urgent or intervention in a way, or education to improve abilities. So based on all of that input, we then developed a free CPD accredited, either in-person or online program. And this included a competency-based test to ensure that the nurses were able to do the P-GALS screening examination. Okay, they were then taught how to record their findings and at what point they were expected to refer their patients. So of all the nurses who had completed the assessment questionnaire, only 19 so far. We only started the project in July this year, so we've had 19 nurses across South Africa completing the program, and 16 of them completed the post-evaluation questionnaire. And the feedback was mostly positive. They found the sessions to be very, very informative, and most of them actually, the confidence increased on the Likert scale. Yeah. So this is just a summary of the before training and after training scores, and I haven't put all of them up here, but just to give you an idea, and it is obviously also statistically significant, but the point is that if you have a good program, this is what you expect to happen, right? You expect the confidence to go up after training, but the real test would then be if you put this into clinical practice, right? So we've got 3 clinics that are actively screening. We had 112 children screened, 16% of which actually presented with abnormalities. We found quite severe illness in many of them, kids who had been left in the community because no one knew what to do with them. And we have in fact had a new diagnosis of FOP, which is like a 1 in a million case. And this child had been from pillar to post, and so just through this awareness program, we actually managed to diagnose and help. So that's been really, really great for us. So in conclusion, I think, the Army of Eyes program really has the right idea. We're going into the communities. We're teaching nurses transferable skills. We're helping them to identify these patients in the clinic, and we're supporting them so that we can have better outcomes for these children. And so I think I'll end just by saying that we do have plans to extend this into the public sort of primary healthcare space. And we do have education and training outreach sessions planned for the first quarter of next year. Thank you.
Well, Heba, that's amazing. It's absolutely, those before and after confidence scores, it's just, it's hitting the spot. Whatever it is, you've got the secret sauce there. That's amazing.
Yeah, I think from other programs too, the nurses are hungry for information, but also for skills, something that they can do, something that's quick and easy, just to help them help their patients. And that's really what it is all about.
I'm sure Haruna's got 1,000 questions about competency-based and whether it's meeting the EPAs. But thank you so much. We must talk. This is good stuff. This is lekker.
Thank you.
Cool.
Thank you.
Awesome. Thank you very, very much. Nomlindo, can you introduce our final speaker?
Thank you so much. Welcome, Summer. Summer will be presenting for us, advocating against genocide as a healthcare worker in South Africa. She's from Paarl Provincial Hospital in Cape Town. Over to you, Summer. Thanks.
Fantastic. Thank you so much. Appreciate it. Just to confirm, can you see my slides and can you hear me well?
Yes, we can see your slides. We can hear you well. Thanks.
Thanks, everybody. So our piece is the Advocating Against Genocide in Gaza as a healthcare worker in South Africa. And just to say that the following authors are the authors on the list, and just to make a special note that we present ourselves as individuals and we don't reflect the institutions that we are working in, so we're presenting in our own capacity. All right, so in this, we're going to go through a little bit, give you some background about the genocide in Gaza, some crisis updates, our role as healthcare workers, as child health advocates, and then go through our aim, methods, results, and some conclusions, hopefully within sticking to our time frame. Right, so some background. So there's overwhelming consensus amongst human rights organizations, Holocaust and genocide scholars that Israel is committing genocide in Gaza. Despite that, advocacy on the behalf of children is extremely difficult and remains difficult. And that is why we need child health advocates globally and locally, because they have a crucial role in responding to this overwhelming catastrophe. So just to go through who has described events in Gaza as a genocide, obviously everybody knows there's an ICJ case where there was possibility of genocide. But since then, we have many human rights organizations that's come out. So people like B'Tselem and Physicians for Human Rights in Israel, their work is very interesting, and I've put the references at the end. Amnesty International, Human Rights Watch, Medical Science Frontier, and then the International Association of Genocide Scholars have come out, as well as specific individual scholars and expert bodies. So just to go through that, and I've just put a full report on that on one of my later slides. So just to go through the updates. So, we've got a tentative ceasefire, quote unquote. And yet what we've seen since the beginning of this escalation is about 69,000 who've died, at least 170,000 injured. But since the ceasefire, we've seen 347 Palestinians killed and 889 Palestinians injured. And yet we've not, really spoken about that in great numbers. And the ceasefire is still being declared a ceasefire. Talking about distribution of aid. So this is according to the 26th of November stats. So essentially 28,200 aid trucks were supposed to enter Gaza, a rate of 600 per day. We're only seeing about 5,458. So really what's coming in is not quite what's been promised during this tentative ceasefire. A report came out from Save the Children on the 6th of September saying that 20,000 children have been killed in 23 months or more than one child killed every hour. And just to highlight that about 1,009 of these kids were under the age of 1. Nearly half of the babies were born and killed during the war. And then just to also put that, there's about 21,000 children that have left permanently disabled, and that is one or more limbs that have been amputated. There's a little bit more about risk and about famine and so on. It's a really interesting article to go through. Just some quick stats. So 18,741 children are treated for acute malnutrition. This is from June 2025. As of November 2025, we've got 58,000 children who've been orphaned. We've got scholasticide in Gaza. This is a bit of an older slide. It's of April 2024, but now we're up to 88% of schools damaged. And then this is just, I put this here because often the mental health and psychological burden of what's been happening is not really being highlighted. And there isn't post-traumatic stress in Gaza. There's ongoing continuous stress. So in terms of the historical context of a child in Gaza, I'm going to go through these quickly, but essentially to remember that children in Gaza are refugees. Many of them are refugees from other places in Palestine during the Nakba of 1948 when the State of Israel was created. So essentially they start off as refugees. And then by the time they are 16 years old, they would have undergone 6 different wars. So that is a child who is born till the age of 16. So just reflecting on the amount of damage and disability and then just psychosocial trauma that the population has already endured and children have endured in Gaza. So why is this important to us? Because as healthcare workers, we've got different domains and areas that we are supposed to contribute to and supposed to define us. And one of the areas is healthcare advocacy. And we're looked to by other people as medical experts, and part of our roles is healthcare advocacy. And why advocate? I mean, I love this little slide, but the truth is, besides doing something about it and the whole concept of if nobody else does it, who's going to do it? When we treat a child, we're treating them in the context of their socioeconomic status. So for example, there's so many different things that impact children. So in terms of treating a child one-on-one, if you're not going to look at their context and the broader issues that surrounding child health, you're really not going to be able to treat children holistically. So if you put a child in Gaza here at the center, and then you try and reflect on the individual social living and working conditions and socioeconomic, cultural, and environmental conditions, it can be something that's very, very overwhelming. You just realize how much one needs to do, and let alone the fact that there's such little medical facilities and medical aid there in the first place. So our aims were to describe the experience of South African child health professionals advocating for respect, protection, promotion, and fulfillment of rights of the Palestinian people in the context of genocide, and active participation and support by the broader child health community. We did a descriptive qualitative analysis of experiences of pro-Palestine pediatric healthcare workers in the Western Cape. And essentially our results were as follows. So we divided into 3 sections. In terms of action, so we mainly collaborated, and most of us are part of Healthcare Workers for Palestine, South Africa, to coordinate a broader activism for Palestine in the area of health. And in terms of children, we've given webinars, lectures, articles, and presentations at departmental meetings. We held a symposium in collaboration with international activists, trying to put the child at the center, regular solidarity demonstrations outside hospitals, engagement with Palestinian students, media engagement, so newspaper, radio, TV engagement to try and improve the public education, and then also supporting the call for academic boycotts and the BDS movement, as well as continuous advocacy in institutions and professional bodies to take a stand. We also did, you have to reflect on the South African and what context and what's happening around you when you are thinking about what's happening in Gaza as well. So we tried to link the two and did an Ubuntu bucket drive and a shoe drive where we raised over R1 million essentially for local kids to get school shoes. So that is a way of trying to marry the two together. The challenges that we faced. So the challenges is quite difficult to reflect on, but I think the biggest part has been speaking up. In no other context or situation have I found it, and others who are working on this hard to speak up. The second you bring up the word Palestine, you bring up the word Gaza, immediately there's intimidation tactics that are set upon you. You get whataboutism, so you often hear things like, well, what about Congo? What about Sudan? What about Ukraine? You get asked to universally condemn every single conflict in the world before being able to speak about Gaza. And often these things are not brought in as a means of highlighting advocacy for the particular groups, which is extremely important and deserves its own space. It's really brought in to deflect and to distract and to move the conversation away. And that happens almost in many spaces, whether it's personal or professional. It just comes up a lot. The other issue is dehumanization, disinformation, and PEP. So PEE is progressive except for Palestine. So essentially dehumanization. So Palestinians have been dehumanized to the point that we've had experiences where if you wear a keffiyeh, which is a cultural Palestinian scarf, and also a scarf of other places in the region, we've had people spit on us. We've had people drive by shouting swear words. We've had people follow us. And it's quite scary how dehumanized the Palestinians are, to the extent that even wearing a keffiyeh could expose you to such things from the public. So that's the one aspect. And then also just in terms of how people speak, often Palestinians and people in Palestinians in Gaza are, put under the same banner. And then just poor mainstream education, attempts at academic censorship, free speech, and labor rights violations, threats to career progression, disciplinary action. We've had it being told to us straight, you're not going to progress in your career if you continue to speak about this. We've had some issues from province as well, which we've had to tackle via trade unions and via lawyers who've tried to declare our protests illegal, and it's not. And there's essentially few institutions that take public stance due to fear or disengagement. We've had situations where, a specific institution wouldn't even accept a food donation because it was via Healthcare Workers for Palestine, even though it was not labeled and it wasn't even packed by Healthcare Workers for Palestine. So these things are happening on the down low. It's quite difficult to speak about. Often collegiality is prioritized over speaking up for children's lives. So you're told, to keep the peace, to not bring things up, to not cause disharmony. And yet all you're asking is for children to stop being murdered. And then personal loss, so relationship breakdown, friends who are not friends anymore, colleagues, loss of community, so these are all things that have happened. And then response fatigue. It's very difficult to keep seeing images and keep trying to continue to be active in the space and to hit such basically, constant challenges and constant threats to your progression, to your career, and to what you're doing. There are lots of positive outcomes, though. We basically had created new safe spaces for open debate. There was informed conversations on human rights. There was identification of barriers on decolonization and inclusivity, and valuable connections were made with human rights and humanitarian and human rights activists locally and internationally. and essentially also just recognizing the needs for further boycotts and just challenging mainstream narratives. The other thing that was really great is new spaces opened up for discussion on children affected by conflict and other genocide. So because often people in Sudan, people in Congo identify and can understand what the Palestinians and people in the LGBTQIA community, for example, understand what it means when it goes, what people are going through. We found ourselves able to align and to be involved in other spaces that were very closed off previously. So in conclusion, advocating for oppressed people is a difficult but necessary step in shaping the world for future generations. And we asked everybody on the call and the child health community in general to say, if not us, then who? And if not now, when? And to try and not be fearful when speaking out, because even though it's very difficult, it is, if you really want to put children at its center, you need to put children at the center. And just to references, so essentially that's all, but I just want to note here that all the pictures that's been in the slides have actually been, so there's Prof. Reynolds, he went to Gaza in 2014, and all the pictures in the slides have actually been on his trip in 2014. So just to highlight to you that this has not been a new issue in Gaza. 2014, Gaza, the people of Gaza have constantly had to rebuild themselves and rebuild their land over and over. And then just looking at this, we kind of wondered with this, how many of these kids are alive and how many of these kids still exist? Yeah, that's pretty much it. Thank you. I'm just going to leave off with my references slides just at the end.
Wonderful. Samar, thank you. Thank you to you and your co-authors and the team behind that. So powerful. Such wisdom and empathy, and really appreciate the way that you framed this and presented and done the work and done the hard yards. Yeah, really is a wonderful journey that you've walked and shared with us. So thank you for that.
Thanks, Dave. And just to Child Health Priorities for actually putting out a fantastic statement and for giving us the space. I don't think you quite realize how difficult it is to speak, to even just present like this. So we really, really appreciate it, and thank you very much.
Brilliant. We're over time. We're well over time, but it's Friday, so we're on holiday now. Any questions for Samar or Saida, Louis? Any comments from the floor? Any questions or that they would like to bring before we wrap it up? Saida, anything to add from your side?
Just to echo what Samar said. So yeah, thank you to everyone for the platform and for listening and to taking the message to their circles. Thanks.
Awesome. Thank you. Louis, no stranger to the Child Health Priorities Conference. Thank you for joining us this afternoon. Lucky to have you with us.
Yeah, I don't think we can emphasize enough how important it is for people not to forget about the genocide. It is ongoing, despite that sort of pseudo ceasefire. And the idea, and this is likely going to happen, that all the Palestinians who've been moved since 1948 from place to place to place to place will be removed from Gaza. And increasingly, it looks like from the West Bank. There's no room for neutrality in a situation like this.
Yeah.
And I do, thank Samar for presenting this so beautifully. I want to call on all people who stand up for children's rights, really, to become a bit more vocal and not to forget about this.
Awesome.
Thanks.
Thanks, Lee. Thank you for that. Yeah, and thank you for bearing witness, and your testimony, your anecdotes and photographs are powerful and an inspiration. Beautiful presentation. Isn't it sad our own colleagues try to silence people? Yeah, Ezra, isn't it just? It's tragic. No more comments in the chat. Nothing else from here. So Marv, final closing comment from your side?
No, just thank you very much, and really encourage everyone to continue to speak up and to continue to advocate.
Cool. Awesome. Nomlindo, anything from your side as we wrap up the afternoon?
Yeah, thank you so much for the presentations. The abstracts were absolutely so brilliant. And remember, it's not all about winning. All of you have contributed a lot and done the best, all of you. Unfortunately, there should be one person who wins, but thank you so much for the great work. Thanks, colleagues.
Wonderful. Thank you so much, guys. Really appreciate it.